run down some things you'd like. What are the tests that you want to confirm the pathogen and the tests that you then want to decide on treatment?
So I want a rapid diagnostic test.
Okay. Which ones? For which bugs?
Well, there's several out there. They are game-changing in the management of infectious diseases.
What are they? Define them for our audience.
So one of the first that came to the market was an instrument by Cepheid that is a PCR-based and could tell you for bacteremic patients if you had MRSA, MSSA, or coag-negative staph. Okay. Now, we implemented that at Ohio State. It was game-changing in the management of staph bacteremia. We could get patients on appropriate staph therapy faster, and we actually had a trend towards a lower mortality. Because, gee, guess what? If you treat them with the right antibiotic sooner, they get better faster.
Really?
Not real surprising.
Really?
But you know, it's nice to have evidence, and that was back in 2010. There's been a plethora of studies by everybody here on the panel that have confirmed that. Rapid diagnostic tests. Sandy's done work with a rapid fungal diagnostic test. So imagine direct from blood. So some of the rapid diagnostic tests, you have to have growth in a blood culture. There's 24 hours, and then you can do the test. But in one of the new T2, it's direct from blood, meaning, in case you're not aware of this test, you draw the blood and you send it to the lab, and in 2 to 3 hours, you know Candida albicans, Candida glabrata. I mean, that's game-changing for an intensivist to know which antifungal actually will work, instead of the paradigm we use for decades. Let me start with my best guess, and in 3 to 4 days, I'll know if I was right. How crazy is that?
If you have that intra-abdominal infection after 2 weeks in the hospital, and you know if antifungal is being considered, but these patients stay on them for 2 weeks because there might be something there and the cultures didn't grow anything. These are areas where we are able to start getting back to your original point. Start anything you want to, as long as you have a path to figure out where you're going with it. And so some of these rapid diagnostics help us get on that path much faster.
I think one of the big issues with the rapid diagnostics, at least in my opinion, there's actually two main ones. One, it requires bacteremia or concern for fungemia or whatever it is in that situation, and we need to get beyond that from that standpoint. But the second thing is I think that people, and I know this because I've spoken with people and I even know how we rolled out at our institution, they do a poor job of telling people what that information that's popping up in the chart comes. If you look at Verigene or any of the ones that give you information, like you can get gram-negative rod, it'll tell you the bug, it'll tell you certain resistance genes. There's like 4 paragraphs of information that pop up, and you can't, it's hard to even know what is positive when you're looking at that. So there's a huge education piece that needs to be there.
So you understand this? Can we give everybody your cell phone number? They can call you. but I think there's... But I mean, my point is, yes, it was a joke, but in fact, somebody's got to distill this.
Well, first you have to get the information to someone.
Right.
You lose all the benefit of a rapid diagnostic if the test result comes at 9:30 and you round it at 8:30 and you're not going to look in the chart again until the next day. Now you've lost 23 hours versus those rapid results. We learned when we implemented PNA FISH 10 years ago, they were coming to a fax on my desk. So if I wasn't at my desk, then they were not acted on unless someone else happened to see the information.
Did you say fax?
I did.
Fax?
I did. Now they come to an electronic in-basket that all pharmacists view 24 hours a day in our hospital, and so a provider will be called if there is an actionable result.
I think although the rapid diagnostics have lots of promise, and I think there are lots of issues that still need to be sorted with them, there are simple first-order issues that need to come well before that. And that certainly comes down with just knowing your antibiogram and getting a reliable antibiogram.
Isn't it at least one of the ABCs, the bedrocks here? Know what bugs you get. Yes. Know what bugs your hospital is prone to, the antibiograms.
Right, and because the antibiogram, you know, you can break it out by ICU versus floor versus different ICUs, you know, your stem cell unit versus whatever, and you can see what your problem bugs are, so you can actually create, and it doesn't take a lot of math, to sit there and say, well, if I want to make sure that I'm getting 90% coverage empirically right for my gram negatives, what's that combination? What X versus Y combination gets me there? And that's the way you're going to get to that. Because again, for a lot of these MDR pathogens, right, MDR Pseudomonas. So MDR Pseudomonas is probably about 20-25% of my Pseudomonas. And about 20% of all my gram negatives are Pseudomonas. So 20% of 20% is now 4. That's 4 in 100, right? Maybe 1 Acinetobacter, 1 C. So now we're talking about 5 or 6 of these super ugly pathogens in 100 patients. That's not a rate at which most people are going to start empirically treating for all of those things. So I need to still come up with what's going to get me to 90%, and then I'm going to worry about that 5% that I'm never going to figure out until my rapid diagnostic or the patient's failure to respond to therapy or the eventual cultural insensitivity guide me to figure out what's going on.
But your thought process that you just described is not done in the majority of hospitals. Most hospitals,
is
if
why
you
we're talking
walk
about this.
around and ask a physician, can you name your top 5 pathogens in your hospital?
And 2 of them
No.
are not hospital administrators.
Right, and so most people do not even know how to access their antibiogram. So
you're
it might be
absolutely
on, and so we've been preaching this for decades, and you're absolutely right in your thought process, but I just don't see it being done in the majority of hospitals unless someone takes ownership of doing it. And the micro lab, you know, there's fewer and fewer microbiologists and microtechs. They're getting short-staffed. You're lucky, we're seeing pharmacists doing antibiograms. I just don't think that's right. That's not our training. Sure, we can learn it, but you know what? It's like if you want the data, you got to do it yourself, and people just don't take the time. But it's
one of the
important.
things we've done is we've required our unit directors, whether they're ICUs, intermediate care units, or floor unit directors, to actually take ownership of understanding and disseminating to the people who practice there what their local specific antibiogram is.
If I may, we have been rounding in our ICUs with PharmDs who know the antibiograms and know the antibiotics and know the bugs in the hospital. It has been a game changer
Absolutely.
for us. We love PharmDs.